Welcome to the conference session titled Managing PNH Complications. Thank you for joining us. My name is Alice Hauk, Senior Director of Health Professional Programs, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your health care. In the beginning of the session, we will open the audience poll feature in the right-hand engagement panel. Please click on the icon in the panel to navigate between each as you watch the session. The poll will remain open for the first 5 minutes of the session. Today's specialist is Dr. Carlos de Castro. Dr. de Castro is a professor of medicine at Duke University Cancer Center. His clinical research projects have focused on new and innovative treatments for myelodysplastic syndromes, paroxysmal nocturnal hemoglobinuria, adult leukemias, and lymphomas. Dr. de Castro serves on the medical advisory board of the Aplastic Anemia and MDS International Foundation. With that said, welcome, Dr. de Castro.
Thank you, Alice, and sorry we can't do this live, but the pandemic has sort of forced us into a new world. The title of my talk today is going to be Managing PNH and Complications, and as Alice mentioned, I'm at Duke University. Just a few disclosures. I do serve as a consultant on advisory boards for Alexion and Apellis, and on a medical steering committee for Novartis, and also a data safety monitoring board for BioCryst. I'm going to be talking about a few drugs today that are not FDA approved, and those are listed here. I've divided the talk into 3 parts. The first is going to be an overview of PNH, including its pathogenesis, because I think that's important to understanding the complications and how we treat them. And the background is a little rain because it's starting out with your PNH diagnosis. I'll switch to complications of PNH, and you'll see the background will change then. And then I'll talk some about the treatments of those complications. And I'll talk about treatments with complement inhibitors as the last part of this with a whole new background. So starting out, and I realize some of you may have heard these talks before, but I'm going to start since there may be some new people here. What is PNH? As the name suggests, it's paroxysmal, meaning it comes on suddenly, goes away suddenly. Nocturnal, occurring at night or early upon the morning when you wake up. And the hemoglobinuria, or the dark urine that we see, and this is the classic form of PNH. Despite this name, most patients don't present this way. About 40% will present with this classic presentation. It is a rare and unusual acquired, it's not inherited, acquired hematological disorder characterized by intravascular hemolysis, that is, the red cells are exploding within the vessels, bone marrow failure, meaning cytopenias or low blood counts, and a tendency towards forming blood clots in very unusual locations, as we'll talk about. And there's incredible clinical heterogeneity amongst patients with PNH. We see some patients who are very sick and some who are very mild, and trying to understand that has been a huge mystery for all of us. The reason PNH is so rare is it takes 2 things to cause it, and they can occur in either order. It does not have to be one after the other. First, there has to be a mutation in what's known as the PIG-A gene in a hematopoietic stem cell. Our stem cells are constantly dividing, and they can acquire mutations all the time. And in fact, we've been able to detect this mutation at a very low level in people who do not have PNH. So the second thing that has to come along is a condition that allows this mutant cell to become the dominant cell in the bone marrow. And we think that's more of an autoimmune phenomenon. That is, your T cells are activated and they attack the stem cells, but not the mutated ones. They attack the normal ones. So the mutation is in this PIG-A gene, which is on the X chromosome. So it only takes one hit to really knock it down or out. Males only have one X chromosome. Females go through a process of silencing one of their X chromosomes. So everybody only has one that's really active. And if you get a mutation in this gene, it results in either partial or complete absence of synthesis of what is known as the GPI anchor, this complicated anchor that takes over 20 steps to form. And this is an anchor that will take proteins that need to be on the surface of cells and anchor them to the membrane of that cell. So if you're missing the anchor, you end up missing the protein that's on the surface of the cell. And there's a lot of proteins that are GPI anchored proteins. I've shown a partial list here, but the two that are important are the CD55 and the CD59 that are on red cells, and they protect the red cells whenever from complement. We'll talk about complement here in a second. So this is the complement pathway. Complement is a part of our immune system. It's a highly evolutionarily conserved set of proteins that will attack foreign bodies, usually bacteria, and make a pore in them so they break apart. They also activate the immune system to phagocytize these cells. We think of complement as having three pathways that activate it. The classical pathway, which is through antibodies reacting with antigens, and that goes through C4 and then C3 and down into C5. The lectin pathway, which is through usually bacterial lectins that are on the surface that will also activate C4. And then there's the alternative pathway, which goes directly in through C3. It requires some cofactors, D and B, that we're going to talk about later. And again, activates C3 and goes down to what's called the terminal pathway, which is C5. C5 activates C6, C7, C8, and C9. This forms a pore in the cell, and the cell lyses. The alternative pathway is always on a little bit. So there's an amplification loop that occurs whenever it gets even more activated. So in PNH, what happens is normal red cells have CD55 and 59, these little green blobs on these cells. And when complement's activated, these red cells are able to inactivate it and they stay intact. In PNH, that shield is missing. And so whenever complement is activated, these cells are attacked by complement. It binds to the cell and they lyse. And this leads to anemia. It also leads to tendencies towards clotting. You can get renal failure, pulmonary hypertension, smooth muscle contractions because the free hemoglobin binds to nitric oxide, and you end up with this abdominal pain and dysphagia that can be quite severe. In males, they can get erectile dysfunction. And if you have enough of this hemoglobin spilling into the kidneys, it leads to hemoglobinuria, or the dark urine. It also can lead to fatigue. So all these manifestations are probably due to complement activation causing lysis of the red cells, and these have significant impact on quality of life and on quantity of life. So I said there's something else that has to come along, and we think that something else is a T-cell mediated immune assault on the bone marrow. Why do we think that? Well, there's this relationship between aplastic anemia and PNH that we've known for a long time. That is, patients with aplastic anemia can have PNH clones and later develop PNH. Similarly, patients with PNH tend to have this tendency towards sometimes evolving into aplastic anemia. And so in aplastic anemia, we think that T-cell assault on the stem cells is complete, and you really knock down the number of stem cells to almost nothing. In PNH, that T-cell assault is probably something a little more selective, so that your mutated PNH cells become the dominant cell in the marrow, and you end up with more hemolysis. Or if it's more the global, but you still dominate, you end up with more cytopenias. So back to the clinical picture of PNH. PNH is a combination of any of these three things. One is the hemolysis that's due to complement activation that leads to anemia. It can lead to severe fatigue that's out of proportion to that anemia. If you have a lot of hemolysis, you end up with the dark urine or the hemoglobinuria, and this eventually can lead to kidney damage. The free hemoglobin binds nitric oxide, and you end up with esophageal spasms, abdominal pain, pulmonary hypertension, impotence, and usually fatigue. Some patients get the blood clots. About 20% will present with blood clots, and up to 40% will develop blood clots over the course of their disease. that has more than not possibly, but is very likely due to complement activation, because as we've gotten into complement blockade, the incidence of thrombosis has gone way down. And we'll talk about the unusual sites of blood clots. And then there's the bone marrow failure, which is due to T cell immune attack with decreased blood counts. So if you block complement, you can take care of these first two problems. Cytopenias do not go away, though, with complement blockade. I mentioned prior to our era of treatments, there was a shortened lifespan with PNH. On average, patients with PNH lived about 13 to 15 years. So, you know, it's one thing if you're 80 and have PNH and you're telling them that you're going to live 13 to 15 years. It's all another thing if you're a 20-year-old and telling them your lifespan is shortened a lot. So it was not a good thing to have PNH. The diagnosis of PNH was commonly delayed because doctors had never seen this disease. It's a rare disease. You'd usually present to your primary care physician and tell them your urine was dark. You might get sent to a urologist who would do all sorts of tests and not realize that it was due to hemoglobinuria, not hematuria. Patients could have chest pain and get sent to cardiologists and other doctors, GI doctors. And often there was a delay in diagnosis that could be up to 3 years. We're hoping with more education that we're explaining to doctors that this is what they should think of. But that's a difficult thing to do. Realizing the signs and symptoms are highly variable and may mirror other conditions. And we could often see these symptoms at presentation, and they were not unique to PNH. So there was a lot of problems making the diagnosis. The diagnosis is based on flow cytometry, and it has to be done on peripheral blood, not on bone marrow cells. We test both white cells, granulocytes or monocytes, and red cells, erythrocytes. If you just do the red cells, because there can be so much hemolysis going on of the abnormal red cells, you may not see the PNH clone there. We use monoclonal antibodies against GPI-anchored proteins such as CD59 or 55. And what we're looking for is the absence of these proteins on the red cells. So here's a typical normal flow cytometry plot. This is a negative control, this line here, and you see all the red cells show evidence of expressing CD59. Here's a patient with PNH where he's got some cells that are normal, and then he's got some cells that are completely absent in CD59, and anything above 1% we call abnormal or PNH. Here's a patient who has a partial absence of CD59 on their cells. And here's one that has two clones, complete absence, partial absence, and then there's normal cells over here. We also use a test called FLAIR, or fluorescent aerolysin, that Rob Brodsky developed at Hopkins. This takes advantage of a protein from the Aeromonas bacteria called aerolysin that binds to the GPI anchor specifically. And by doing that, you're not looking for one antigen, you're looking for all the GPI anchors, and therefore you get a greater signal to noise and better accuracy by doing that. So CD59 binds there, FLAIR will bind here and pick up all the GPI anchors. So it's a more sensitive test. And we use that commonly on the white cells of patients. Can't do it on the red cells because they bind this protein non-specifically, so it doesn't help us. I just want to mention clone size. Clone size refers to the percentage of bone marrow stem cells that are the mutated cells or the PNH cells. We don't directly measure that. We don't do a bone marrow biopsy and say how many cells are mutated. We do it from peripheral blood, and we estimate it from the white cells, from the neutrophil or monocyte results, not the red cells as they're being destroyed, so they give a low value. In general, the larger the clone size, the more likely the patient is to have hemolysis and complications such as thrombosis. So we can use that as sort of a prognostic marker, but it is not a hard and fast rule. I've seen patients have blood clots with PNH clones less than 10%, which we don't usually expect. So you have to be careful using the clone size. So as I mentioned, I'm going to switch now to some greener grass and talk about complications of PNH and how we approach these and treat these. And I'll mention some of these in more detail than others. I really want to get down to the special situations that are listed down here, including COVID, the elephant in the room. So let's talk first about blood clots. I'm not going to talk about cytopenias. Cytopenias occur in patients with PNH. We treat them much like we do aplastic anemia. If they're severe, we give immunosuppressive agents. If they don't respond to that, we consider a bone marrow transplant. But most of the time, that's a separate topic. Blood clots are probably the most feared complication of PNH. As I mentioned, they occur in up to 40% of patients, and they contribute to end organ damage. They damage the lungs, the liver, kidney, brain, heart. They can go all over. And prior to our developing treatments for PNH, they were the leading cause of death, at least in the Western world. 40 to 2/3 of patients died from blood clots. And once you had a blood clot, your risk of death went up 5 to 10-fold. Blood clots could be the presenting symptom. The first thrombotic event could be fatal. The biggest problem we had is, despite having anticoagulants that were very good, patients tended to reclot even on anticoagulants. So once we saw a blood clot, we were very worried that the patient was going to clot again. They may be correlated with the size of the white cell clone, and they may occur in funny locations. And here I just have a pie graph of where they occur. You see here in the blue and dark blue, these are deep venous thrombosis, or DVTs as we call them, in about 1/3 of patients in typical locations. But this other third occurred in the GI tract, mesenteric and splenic veins, or hepatic portal veins. Something called Budd-Chiari syndrome could occur, where we totally occlude off the liver. And then you have a lot of other clot sites, including cerebral, dural veins, very unusual to see, superficial dermal veins in the skin. We can have arterial clots, strokes, and arterial and heart attacks occurring. But this big thing that occurred in the GI tract was very unusual. And when we see somebody with a GI tract clot, we should often send off a PNH screen to make sure they don't have PNH. How do we treat clots? We used to put people, Coumadin prophylaxis to prevent clots was a controversial topic. I think that's gone away now in the age of complement inhibitors. But if you get a blood clot, we would try to acutely treat it with lytic agents or clot busters to bust apart that clot. We would put patients on anticoagulants, and there's newer ones that can be used. And we would strongly, in the old days, consider a bone marrow transplant, because we knew these patients were at risk of clotting again and again and dying from their disease. I'm going to just show you later on the data with C5 inhibition, that is eculizumab or ravulizumab, where the incidence of clots has gone down highly significantly, over 90%, so that blood clots really are not as feared as they used to be. And we don't have any data yet on pegcetacoplan, the drug that was recently approved, which is a C3 inhibitor. But we suspect that it's going to be similar to the eculizumab and ravulizumab data. Special situations. Surgery is a condition that we have to be concerned about PNH patients. Surgery activates complement to various degrees, but it can be fairly high. And if you're not protected, you can have a hemolytic flare from that surgery. In addition, both immobility and PNH and increased complement levels can lead to blood clots. So we used to worry about these patients getting blood clots while they lay in bed recovering from surgery. So what we recommend for patients who need PNH patients who need surgery, if it's an elective surgery, is that they should receive their complement inhibitor just prior to their surgery. For eculizumab, we like that for to be 3 days from the dose of eculizumab. For ravulizumab, that's given every 8 weeks, we like for it to be within the 2 weeks of having had a dose. In addition, we can consider adding steroids or anticoagulation prophylaxis on these patients. I think that has to be done on a case-by-case basis. Pregnancy. Pregnancy was always used to be a problem with PNH. In fact, we used to advise PNH patients against getting pregnant, in part because the risks to the fetus and the mother were so high. We know PNH is a hypercoagulable state. You can form blood clots. Pregnancy is also a hypercoagulable state due to the high estrogen levels and compression of the veins by the enlarging uterus. And several studies, these are old studies going back, documented that pregnancy during PNH was not a good thing to have due to the risk for blood clots and due to the risk of miscarriages and hemorrhage and bleeding and clots, such that, again, if a female of childbearing age came to us with PNH, we used to strongly discourage them undergoing any sort of pregnancy if they could avoid it. Now that's hard to do because obviously everybody would like to have kids at some point. Not everybody, a lot of people would. So it's always a very difficult discussion. So I'm going to talk just briefly. There's emerging data. This is an old slide of data using eculizumab in pregnancy. It came from this patient out of this paper out of England by Richard Kelly, using eculizumab in pregnant patients, showing that the incidence of in 75 patients who got pregnant while on eculizumab, there was no maternal deaths. There were 3 fetal deaths and 6 miscarriages, but it could be done safely. And so if somebody now wants to get pregnant with PNH, we strongly recommend that they be on eculizumab. There's no data yet on ravulizumab, although we suspect it will be similar to this. And obviously we have no data on using anything such as pegcetacoplan yet. So summary of this paper was overall our findings show acceptable outcomes when eculizumab treatment was used in management of PNH in patients during pregnancy. We still require specialists in PNH patients during pregnancy to make sure everything goes okay. Now to the big topic, special situations, COVID-19 infections in PNH. There are several case reports out there, such as this one, showing a, quote, mild clinical course in a patient with PNH who was on C5. And we can go through these. There's another case report on a patient that had a difficult time. Another one, severe infection, and this patient ended up being in the unit and hospitalized. And then another one, and a patient treated with eculizumab, and they got SARS and went through a hemolytic crisis, but survived that. And then our colleagues out in England came out with 2 papers. The first was published by Austin in last year in the British Journal of Hematology. They had 4 patients, and they suggested that the complement inhibitor that they were on, their eculizumab or ravulizumab, led to a less severe course of COVID. And then their competitors or colleagues at Leeds came back with 4 other patients and said, we've had 4 patients also, 2 had severe, 1 died, and they were all on complement inhibitors. So whether complement inhibition helps during COVID infection is not clear. We're still waiting for some of the trial results to come out. But I think we all have to still be wary about COVID infections in PNH patients because there's so much complement activation that they can have hemolytic crises and can have bad outcomes. Anecdotally, I have had 1 patient that I've treated that developed COVID-19. He had a very difficult time, ended up in the intensive care unit, went on dialysis for a while, had heart issues. He has recovered, but it's taken him a year and a half now to get fully recovered from, actually not even fully recovered, to get recovered to the point where he's feeling better. So what about the vaccine? Also another difficult topic. Recently, a letter to Blood came out from Dr. Brodsky's group at Hopkins, looking at the issue of COVID-19. In the old days prior to complement inhibitors, we used to not try to vaccinate our patients, in part because things like the flu vaccine activate complement, and we could see flares in disease. And certainly the COVID-19 vaccine is not any different. It also seems to activate complement, whether it's the Pfizer, Moderna, or even Johnson & Johnson. They all seem to have this effect. And so they reported on patients with who had undergone COVID-19 vaccination who ended up with hemolytic flares in their disease. And so what did they recommend in the end? Both the infection and the vaccine can have severe inflammatory states, complement activation, leading to adverse effects. They still recommend vaccinating patients for COVID-19, only because I think everybody knows that the virus can be very difficult. And they do that within 4 weeks of the last ravulizumab or within 1 week of eculizumab, hoping that we have high enough levels to block complement activation and that patients will do well. And the adverse reactions they saw were time limited and can be managed with supportive care and transfusions as needed. and that is true. I think we are still all strongly recommending vaccination against COVID-19, but we have to be aware that this can sometimes lead to flares in hemolysis, and patients should be aware of that when they get their vaccine. So now that we've talked about complications, I want to just wrap up by talking about current treatments for PNH. And I've put the sunrise here because we're into a new era now where hopefully everything will turn sunny rather than rainy. We're going to talk about complement inhibitors. The ones that are FDA approved are shown here: eculizumab or ravulizumab, and now pegcetacoplan. Severe care is also important. For bone marrow failure, if it's severe enough, we recommend ATG and cyclosporin. And allogeneic stem cell transplants have a very limited role nowadays. And our goals are to correct anemia, to improve quality of life and reduce fatigue, and reduce the risk of all these complications that I just mentioned. Eculizumab was the first drug that came out for treating PNH. It was a C5 antibody developed by Alexion. It was humanized and it was engineered so that it wouldn't activate complement itself. And eculizumab binds to C5. C5 was picked because it was felt to be one of the safest targets at the time. We were worried if we targeted C3 or earlier parts of the complement cascade that we would see a lot of infections. So we blocked C5. And by doing that, all the terminal pathway was completely blocked. You didn't get pores formed in cells and you didn't see hemolysis. And there were 3 studies that led to the eventual approval of this drug. The first occurring back in 2004 when Pete Hillman reported on a pilot study out of England with 11 heavily transfused patients who were always hemolyzing, and all 11 responded to the drug. This went on then to a phase 3 study, so it would get approval, called Triumph, and another study called Shepherd that was broadening the patient population. And all of these patients then went into a long-term extension study so they could remain on drug after the initial studies were finished until the drug got eventual approval. As I mentioned, blocking C5 does have one serious complication, and that is meningitis from meningococcus. So everybody should now be vaccinated against meningococcus. There are 2 vaccines that you need to know about, the typical meningococcus vaccine, and then now the meningococcus B vaccine. The standard meningococcus vaccine is every 5 years. The meningococcal B vaccine, we're waiting to hear, but right now it's a once in a lifetime, but I suspect they're going to come out with revaccination guidelines eventually for that one. And then everybody should be aware and carry a card around that if they have any signs or symptoms of meningitis, they should go to the ER right away, and the ER doctor should be given information so that they can quickly start the patient on antibiotics as soon as possible so that we can avoid complications from the meningitis. This is from the Triumph and Shepherd study. This is just the LDH, which is a measure of hemolysis. You can see here the patients that got the drug initially, quickly within 2 weeks, their LDH levels went down to near normal. Patients who were on the placebo arm of the Triumph study did not get it until they went into the extension phase, and then they quickly dropped their LDHs down to near normal, meaning we were blocking hemolysis very quickly. Transfusions, which were in hemoglobin stabilization, were the main primary endpoint of these studies. You can see here on placebo, these patients fell back down to their usual levels, whereas we got eculizumab, you stayed at a higher level and didn't need as many transfusions, if at all. And so hemoglobin levels rose, but they did not go totally to normal. On average, they were in the 10 to 11 range, interestingly enough. Fatigue scores were markedly improved if you got this drug. Whereas if you did not get the drugs, you kind of wondered, and when you realized you weren't getting the drugs, you actually felt more fatigued. And so in summary, eculizumab quickly and significantly reduced hemolysis, the underlying cause of morbidity and mortality in PNH. There was an 86% reduction in hemolysis, a 92% reduction in thrombotic events, a 73% reduction in transfusions, and significant improvement in quality of life measures. And for the most part, the adverse events were very similar to placebo. This drug does not treat bone marrow failure, so you won't see your white cells or your platelets go up on this drug. And it may not completely restore the hemoglobin level because there probably is a minor degree of what's now known as extravascular hemolysis going on in these patients. As time has gone on, there are 2 papers out there that have looked at survival now since eculizumab came out. And you can see the survival curve. This is prior to eculizumab and what it looks like nowadays. Survival is almost near normal. We are extremely pleased that a drug can do this to any patient group, and especially PNH patient now. Ravulizumab is now out there. Ravulizumab is long-acting eculizumab. It's basically been modified so it stays in the system longer. There were 2 studies done on ravulizumab comparing it to eculizumab. One was in naive patients. The other was in patients that switched over that had been on eculizumab. Both of these showed a non-inferiority to eculizumab. These were not big studies looking at superiority. So we can't say that ravulizumab is better. It is certainly more convenient to get a drug every 8 weeks than every 2 weeks. And in fact, the levels you get with ravulizumab that block C5 are actually higher. So there's always this, maybe it does work better. Maybe we'll see less flares, but we can't say that with 100% confidence because we just haven't done that sort of study. Most patients in the United States are now switching over to ravulizumab, as I mentioned, just because it's more convenient to get an every 8-week dosing, and they're actually coming up with a higher concentration so that the infusion times won't be as long. So we have eculizumab and ravulizumab out there. They are standard therapies by far. They clearly improve survival and quality of life, but there are still a number of patients that have undergoing low-level hemolysis, some more so, to the point where this may be a little bit high of an estimate, but we say 10 to 20%, some people are saying 25 to 35% of patients are still requiring red cell transfusions, are still anemic, and are still having issues. We call these patients suboptimal responders. And we think that this is mostly probably occurring because eculizumab, while it binds C5, C3 can still coat the red cells, and C3 leads to extravascular uptake in the liver and spleen and destruction of red cells if they're coated. Why some patients have more of that and others have less, we don't know for sure. So as I mentioned, anywhere from 5 to 20% of patients are now showing a suboptimal response, continued hemolysis and or transfusion need to eculizumab and probably to ravulizumab. And we think most of this relates to this C3 coating of the red cells that's ongoing. So this is from a paper that Anita Hill published and Antonio Versitano. If you have red cells, PNH red cells in your circulation, and you have no eculizumab treatment, these cells are destroyed rapidly through the formation of the MAC complex in intravascular hemolysis. If you are on eculizumab, these red cells survive and are getting coated with C3 or fragments of C3. And in some patients, this is high enough that they then go through extravascular hemolysis, get more anemic, get fatigued. They may have a minor increase in their LDH. Most of these people were picking up by having an increase in their reticulocyte count. So there are a bunch of drugs that are now emerging that hopefully will take care of this problem, or we're at least experimenting with them. We need to have long-term data on these drugs only because we worry about the safety of blocking C3 or earlier parts of the complement pathway and infections. For C5, we've got eculizumab and ravulizumab. Crovalimib is being tested, and there's a few others that I haven't listed on the slide that block C5, but they still don't address the problem of C3 coating. Pegcetacoplan was recently approved. I'm going to show you the data on that. It blocks C3. And there are 2 drugs that are oral that are going to be used to block factor D, a cofactor in activating C3. And there's one drug by Novartis that also blocks factor B that's oral that they're hoping will be useful. So C3 inhibition with pegcetacoplan in PNH patients who were already treated was a way of getting around this. We were looking for suboptimal responders who had a lower hemoglobin or were getting transfusions to support themselves. And we did this early phase study. That was a phase 1/phase 2 study looking at C3 blockade in these patients. These are the last cohort where we reached therapeutic levels. So I don't show you earlier cohorts because we didn't have complete blockade, but at least at these levels, you can see what happens in this case to complement measured by CH50. You want that to go down. There was one patient that had to come off for a serious infection, then went back on the drug, and their levels came right back down. So it blocks complement activation very nicely. And this slide, which is hard to read, I realize, it just looks at various levels such as the hemoglobin, the reticulocyte count, LDH, and in all these patients, they responded beautifully. And these were patients who were having suboptimal responses to eculizumab, usually at higher doses of eculizumab. This led then to a phase 3 trial that was published in the New England Journal in March by Pete Hillman. And I'll just read you the conclusions of the study. Pegcetacoplan was superior to eculizumab in improving hemoglobin and clinical and hematological outcomes in patients with PNH. These were patients who were on eculizumab and had a suboptimal response. So in a sense, it was a study that was designed to win because obviously if you're not responding well to eculizumab and you stay on an eculizumab, you're probably still not going to respond to it. Whereas pegcetacoplan clearly looked better in this study that blocks both intravascular and extravascular hemolysis. So here's how the study was designed. There was a 4-week period where patients got both drugs, and then they were randomized either to continue eculizumab or to go on pegcetacoplan monotherapy alone. After the 32-week endpoint, if you were still on the eculizumab arm, you could then go on both drugs for a while and then be flipped over to getting pegcetacoplan alone. The age and the criteria for these patients is shown here. Again, these are all suboptimal responders with hemoglobin levels that were in the 8.6 range and higher retic counts, again, showing that they were still having hemolysis. And here's what happened to these patients. During the 4-week run-in period, almost universally, all of them had a rise in their hemoglobin from about 8 up into 11. Those that stayed on the pegcetacoplan monotherapy stayed in that same range, around 11. Those who were back on the eculizumab alone fell back down to their previous levels, around 8 to 9. So clearly this drug worked better in these suboptimal responders. And you see here, hemoglobins at baseline going from 8.7 up by week 48, where they were staying on the drug, up to 11.3. If you were on the eculizumab, you were 8.7. By the end of that eculizumab infusion, you were 8.6. And then when you flipped over, we could get them back up into that 11.6 range. So a higher hemoglobin was clearly achieved in the study. There were a lot of secondary endpoints that I show here, all favoring, again, the pegcetacoplan arm over the eculizumab arm. Safety, the drug appeared safe. We were concerned about infections. We did not see that. There were patients, though, that had breakthrough hemolysis. 9 were on the eculizumab arm, 4 were on the pegcetacoplan arm. The 4 on the pegcetacoplan arm, because this was an experimental drug, had to come off the drug if they got breakthrough hemolysis and were put on back on eculizumab. And we were trying to understand these events as to what caused them. I will say that 3 out of the 4 patients that had this hemolytic event were overweight, and we're wondering if it was just a dosing issue because it's a standard dose we give. And so the company's debating whether we should give higher doses. And what to do for rescue of these patients, anybody who's now on this drug, is still unclear. This is a sub-Q drug, so there were injection site reactions. They're mostly mild, people learn to live with it. And there was diarrhea, which was mostly mild, and one was moderate, and there was no dose change due to the diarrhea. So the conclusions of the study were that Pegasus trial showed that patients with persistent anemia, despite eculizumab therapy, pegcetacoplan was superior with respect to improving hemoglobin, as the primary endpoint of the study. And also all the other secondary endpoints were also superior, although there was non-inferiority kind of statistics played there. So it looks like this drug is wonderful. The FDA, in their great wisdom, approved it for all patients with PNH, not just those who are suboptimal responders. Whether that's where it should be used or not, I think is still going to be a big debate in our field. I would favor using the drug that is still well known, that we know cuts down clots, we know improves survivals, And if they're suboptimal responders, then of course I would put them on this drug. But we don't know about should we be using this drug up front. If it looks better, why not? It is sub-Q, twice weekly. Some patients would rather have an IV infusion every 8 weeks than a sub-Q device attached to themselves at home twice weekly. But that's purely a patient preference. What to do for these patients, I think, is still unclear. I think it's clear that the patients have extravascular hemolysis, that they're suboptimal responders. This drug is clearly superior, and I would have no problems recommending this drug. I mentioned there's a couple drugs that are still undergoing investigation. I'll mention the two that are undergoing phase 3 studies now. First is iptacopan, which is being developed by Novartis. This is an oral factor B inhibitor, which is a cofactor for C3 activation in the alternative pathway. We have a phase 2 study that was published by my colleagues out of Europe. And you can see here the mean drop in LDH and the rise in hemoglobin in patients who were on this oral drug. It was wonderful. 7 patients were able to discontinue eculizumab and just continue this drug as monotherapy, so it seems to work on its own. And there were no treatment discontinuations or treatment-related adverse events. So again, a very nice study showing activity of this oral factor B inhibitor. It is, and this is the red cell transfusions before and after study. So you can see patients who were getting transfusions no longer needed them. So this drug looks like it's going to be effective. It is now in phase 3 trials. We are hoping to open up trials in the US here very shortly. Our colleagues in Europe are quicker at opening up trials, and they've already opened theirs and are comparing this to standard therapy. Just some more data, again, showing that it works very effectively. Side effects are shown here. Again, they were, for the most part, mild and low in number. So it has received breakthrough therapy designation by the FDA. The phase 3 trial has started and will hopefully start in this country shortly. Oral therapy may be a very nice way to treat patients instead of IV or sub-Q. And we still just need additional safety data. We are happy that we have the choices for therapy, and we're going to have to figure out which patient should receive which drug. With oral therapy, there's always the concern about what happens if a patient misses a dose or is non-compliant. Are they going to have a big hemolytic flare? But I think, we've learned with oral anticoagulants that patients do take them and are instructed not to miss doses. The Danicopan, being developed now by Alexion, who purchased it from Achillion, is this oral factor D inhibitor. It also has data out as shown here. It blocks factor D, which is a C3 cofactor, so C3 doesn't form. Phase 2 study has been published. It's again an oral drug. It's 3 times a day, so a little bit more inconvenient that you have to take it 3 times a day. The phase 3 trial has started on this, and we are hoping to open this up at Duke also in the near future. It's an add-on therapy right now to eculizumab in patients with PNH and extravascular hemolysis. We will see if they ever decide to open it up to monotherapy, but right now they want to just do it as an add-on study. And again, it could be another oral compound that we can use in our PNH treatments. I'll briefly mention this drug, BioCryst, BCX9930. It's another oral factor D inhibitor that's out there. Again, it blocks factor D, which is this cofactor for C3 activation. You block that amplification loop, you get less complement activation. It's being tested in a lot of different diseases as shown here. The PNH proof of concept study has been completed and patients are on extension. Most of these are in South Africa, a few in the United Kingdom and Austria, where there is no, in South Africa, there is no availability of any complement inhibitors. So you can give it easier to patients there. And you can show here again, patients respond with their hemoglobin going from an average 8.3 up to 11.8. The reticulocytes going down, LDH going down, bilirubin's going down. All measures of hemolysis, patients are responding to this drug and doing very well. You see here transfusions, and the patients were receiving transfusions. After they got on this drug, nobody needed a transfusion, and everybody remained transfusion free. So this is an early study. It looks very nice. as another treatment for PNH. And they are just now opening up their phase 3 study that's going to randomize patients. So the hope is to get that open soon in the US. I'll just briefly mention others that are out there. These are mostly C5 inhibitors. I'm concerned about whether these will still have the problem with C3 activation on red cells and extravascular hemolysis, but these companies are hoping that they won't, and we'll have to wait for their data to come out. So in conclusion, there are new therapies that are coming out that have activity in different points in the complement pathway. We need further data, and I appreciate patients who have been on these studies, long-term safety data, comparative efficacy, there's the convenience of how these are administered, and there's, unfortunately, on the other side, the risk of hemolysis if you miss doses. But we're hoping that these new treatments will lead to improved outcomes and certainly better quality of life in all of our patients. So I just want to say thank you to all the patients who are out there and the clinical research trials group who make this possible at Duke and all over the world. And I will open it up at this point to any questions that y'all may have.
Thank you, Dr. Castro. We do have several questions. First one is, at what point with developing decreased kidney function, GFR, should you consider starting treatment for PNH if your clone size is small?
Oh, wow. So if your clone size is small, the question then becomes is how much of the kidney failure is due to hemolysis, or is it due to other causes? I think that may be one of the few rare cases where you need to rely on your nephrologist and ask, is a kidney biopsy necessary to look for what's called hemosiderin or iron deposition in the kidney. And if we find that, then I would say, yes, it's time to start a complement inhibitor to stop the hemolysis.
Thank you. Next question. I have classic PNH and I'm prednisone dependent. I'm anxious to determine how much immunity I have from my COVID vaccination. Do you know if any reasonably accurate tests are under development? Are you familiar with the VaxEffect test that was?
There's lots of them that are out there that I don't know how good they are, and I think we're all waiting for the data on looking at antibody levels. There are some studies going on, like at the NIH, I know, to look at post-vaccination antibody and determine how accurate it is and how good it is. But currently, we don't have enough data to use those clinically in our clinics or elsewhere. People are using them, but I don't know how to use them well.
Okay, thank you. Does the newest drug show to reduce severe fatigue at all?
Yes, there were quality of life studies that were done with it also, and yes, they do seem to improve their fatigue scores on this drug, especially if they're suboptimal responders.
Are there tests that specifically test for extravascular hemolysis?
Not 100%. The best test is still the reticulocyte count. So if you are on a C5 inhibitor and you have a high reticulocyte count, that means you are still destroying your red cells. And by implication, that's likely going to be extravascular. We will look at the LDH and the bilirubin. The LDH is usually only very mildly elevated in extravascular hemolysis as opposed to intravascular hemolysis.
The next question is, as a male with PNH in his 50s, with hemoglobin levels around 10 to 11, with severe fatigue, would there be benefit from adding on or switching to the newest drug?
My answer to that is yes. What we saw in the studies in these patients were they felt much better once they got on the new drug. So any degree of ongoing hemolysis can lead to this fatigue issue. Probably not related to the degree of hemoglobin. And if you block that, we saw a lot of patients just report, wow, I feel so much better. So I would say, yes, I would consider trying that in that patient.
And can you clarify what you meant when you said that someone on a C3 inhibitor might be more susceptible to infection than if they are on a C5 inhibitor? So
the concern comes from children who have congenital deficiencies in complement. So if a child is congenitally deficient in C5, The only type of infections we saw in those were Neisseria infections and Neisseria meningitis. If you're deficient in C3 or earlier points in the pathway, kids with that had all sorts of problems, all types of infections. And so our concern was always, hey, if we block at C3, are we going to be putting people at risk for more infections with all sorts of bugs? We have not seen that yet. In all the studies that are being done on all these different pathway inhibitors, we still have not seen an increase in infection rates. Some of this may relate to the fact that in kids who are congenitally deficient in C3, their immune systems never really develop, and so they're always at risk for more infections, even as they start to grow up. Whereas in PNH, no, the immune system's fully developed, so your T cells, your B cells, and other can take over and make up for blocking C3. But it is a long-term concern that we're following in all these patients on C3 inhibitors.
Thank you. And as a closing comment, actually, we're asking you to share with patients the importance of their participating, if they can, in the new global PNH patient registry that AAMDS has inaugurated in cooperation with the National Organization of Rare Diseases. We will have there is a session scheduled here in the conference with much more detail about that. But from your perspective, if you could share why that's
my
important.
perspective, it's a wonderful, wonderful idea to participate in this global registry. The previous registry, which was done, was physician directed. It had a lot of issues with data being put in, who was putting it in, who was paying for it all. That I think this one is a much better idea, where it's patient directed and patient sort of run, and we can collect data from it and use it to help us in the future.
Thank you. And that concludes the question. Thank you. The question and answer session. Thank you, Dr. Castro, for sharing your time and expertise with us today. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If you were not able to answer your question today, you can send it to us at any time in 3 ways. You can send it in an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. Be sure to visit the exhibit hall. The next educational session will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family, as we have for the past 37 years. This concludes the session.